So this session here, that was sort of our tee-up session, building on values and looking at then and now and what for the future. And now what we're going to do is reflect on the state of sort of the health services. What were the pressing priorities, which Steve will deal with for us? What were the sort of pressing, what were the financial kind of constraints and conditions under which we were working then and now as we move into the future? And then what are more of the political constraints? So what is the dynamic, that federation, how is that working? And those our three speakers will address each of those. So they're just going to be speaking for about 10 minutes each, and then we're going to open it up to commentary in the same way that we have, starting with Steve Morgan from the Center for Health Services and Policy Research, followed by Matthew Mendelsohn, who's the director of the Mowat Center at the University of Toronto, and then Antonia Maioni, who is with the Department of Political Science at McGill University. So I'm going to call on you now, Steve.
So thank you very much for the invitation to speak here today. It's a privilege, and I really appreciate the opportunity. I was actually asked to cover the landscape of policy challenges at the time of Romanow and how they've evolved over the 10 years since as it related to wait times, home care, pharmacare, and as Lillian put, ... on the invitation to speak today. All in 10 minutes, which is equivalent to talking about $40 billion worth of health reforms over 10 years in 10 minutes. I'm not going to do as I was told. Rather, I'm going to speak to what I think is one of the most pressing, unresolved health care issues in this country that Romanow addressed in the recommendations, but we've seen little progress on. And that relates to the prescription drug coverage in Canada. And I'm going to put together a proposition that suggests that we could probably actually save, rather than spend, $40 billion over 10 years in the pharmaceutical component of our healthcare system while improving quality of care, equity of finance, and the sustainability of the system, all in 10 minutes. So we are all aware of Medicare. In fact, most Canadians have this sense, a very deeply felt sense of what Medicare means to them. It's a universal public system for funding medically necessary care. It's conscribed right now around care provided in hospitals and care provided by physicians. But as Greg mentioned earlier this morning, the intention at the outset of this program was it was policy in stages, and that there would be additional components of the healthcare system that would be added. And one of them, mentioned in the 1960s, again in the 1980s, 1990s, and with Romanow, one of those additional components was pharmaceuticals. Now, very few Canadians will realize that we are probably the only country in the world that offers a universal system of healthcare financing that excludes prescription drugs. Medicare, as we know it in Canada, effectively stops as soon as a doctor has handed a patient a prescription. And that is unique amongst all comparable countries. The one country that we're closest to and we tend to like to compare to most often is the United States, but its system, at least not yet, hasn't even achieved the basics of universal access to medical care and hospital care. And even when they get there, when Obamacare arrives in a few years, they may actually surpass us on this particular policy file, which would be even more embarrassing than the data I'm about to show you. I want to go back and look at what's happened in the post-Romanow years in terms of prescription drug coverage in Canada, just to give a sense of where we're at and where we've been. And I'm using this color-coded diagram. I'm so pressed for time, I just want you to look at the colors. Red means no public coverage for the population that we'll be looking at in the provinces that we'll be looking at all. So completely uninsured for prescription drug needs. Moving all the way up through catastrophic coverage, which only covers costs that exceed very high deductibles, so people have to pay out of pocket or through private insurance first before government kicks in. All the way up to blue, which is Medicare-like first dollar coverage with minimal co-payments. This is how our history across provinces in time from 2000 to 2010 looks like in terms of covering persons on social assistance. We actually have a Medicare-like level of coverage for prescription drugs for people who are society's most vulnerable, those on social assistance. This coverage has gotten marginally better over the decade post-Romanow, but interestingly enough, it wasn't the focus of Romanow's recommendations. This is the picture of benefits for the elderly. And what you'll see here is actually a slight increase in the amount of pink. We seem to move this transition from blue, which would be more generous or more comprehensive public coverage, to pink or red, which is catastrophic coverage or coverage only against very, very high drug costs. And that's potentially troubling given that this is a population subgroup that actually needs medicines on a chronic and persistent basis. Having catastrophic deductibles under those programs is tantamount to taxing the elderly for their annual health care needs. And lastly, if I can get that to work. Oh, I've gone too far. Benefits for the non-elderly. This is the gap that in our pharmacare patchwork that we were hoping to fix following Romanow. And this is an area where in Atlantic Canada, at least, we have seen some progress where provinces acting on their own, because there has been, in effect, no federal transfers for these programs, but where the provinces have established catastrophic coverage for populations that previously didn't have coverage. But what's notable is there's no dark blue in this slide. In fact, there's very little dark blue in the slide previous relating to the elderly coverage, which means, as I said before, Canadians, for the most part, don't have coverage against the cost of medically necessary prescriptions. I just want to quickly use some of that Commonwealth Fund survey data that people have been talking about already this morning to show how Canada fares against comparable countries abroad in terms of access, what we might call equity in terms of financial burden on patients, and then sustainability of the system in terms of the cost growth over time. First of all, as it relates to access, we're going to look at financial barriers expressed in terms of patient-reported cost-related barriers to filling their prescriptions, basically the percentage of the population that reports that they cannot fill their prescription because of costs. And this is the bars that I want you to pay attention to. Blue is the United States, which after Tuesday's election is fitting. Red is us in Canada. And the green bars are comparable countries abroad where they have universal systems of prescription drug financing. You'll see here that the Americans have the greatest barriers to accessing medically necessary drugs because they have the least insurance for their population. Canada fares fairly poorly in this regard because many people fall through cracks, and many of our public programs impose co-payments that we know serve as a barrier to people filling prescriptions. Every credible study about this shows the same thing. If you charge patients for the prescriptions they fill, they will fill less or fewer prescriptions. And this is not always a good thing. Australia, amongst the countries that we might compare to, stands out in part because they actually charge very high co-payments. They charge $35 under their universal system of prescription drug coverage in Australia, and it shows up in the rates of financial barriers to care. How about those co-payments when they add up over time? The out-of-pocket costs for the uninsured, the co-payments for the insured, what does it look like in terms of financial burdens? I'm going to show some data that relate to the percentage of people with chronic disease that report expending over $1,000 per year on their prescription medicine needs. And in this regard, Canada can only look good against the United States, but I hardly think that's a relevant comparison for us. The green bars, comparable countries with similar healthcare systems to ours, all perform far better at protecting people against the financial burden associated with their illness. And I think this is, in a sense, a national shame that we would allow people with chronic disease or people with cancer to bear high out-of-pocket costs when they didn't choose to be ill. They didn't choose to be sick. And this gets to my final line about what is the burden to society. The systems that are universally financed through some mechanism that is reasonably integrated to healthcare actually offer opportunities to manage expenditures in ways that we can't in a fragmented multi-payer system. The incentives don't seem to line up well, whether it's in Canada or in the United States. And this chart really shows that, I think, as clearly as one can. Canada and the United States are the highest two spending countries in terms of pharmaceutical expenditure in comparable countries. In fact, in the OECD, we are the two highest spending countries in the world. And yet all of the comparators below here have universal systems of prescription drug coverage that protect people from bearing significant financial burdens and encourage them to be able to access the medicines they need. Lower cost, better quality, better equity. If you don't think that this particularly matters, if you compared Canada just against Germany, the next highest spender in the countries we've compared to today, if we had their level of spending, the next highest level, we would be spending $4 billion a year less per year on prescription drugs as we do today. And yet we would have universal coverage for all people and all prescriptions subject to relatively modest co-payments. If you compared us to the NHS in the UK, we'd be saving on the order of about $10 billion, with a B, billion dollars per year in the prescription drug file. So universality and comprehensive coverage, as we know with Medicare, can be an instrument both to access, quality, equity, and importantly, as an economist, sustainability. I'm going to gloss over 2 slides here, if I can move the deck forward, which I can't. A lovely photo that I'll explain later. Another lovely photo that I'll explain later. And just to end here, we've already heard this story about the fact that we need to gain greater focus and have some clarity. Changing a system as big as the pharmaceutical financing system in Canada will require clarity and leadership around ideas about where we're going. In February of next year, we're hosting a conference to do just that, and I hope to begin what is in effect a movement where it's a dialogue amongst stakeholders and patients and elites, like the people in this room, about what are the goals we really want to achieve with the system. Set aside the politics of what the system might look like. Let's just get agreement on goals, and then let's assess objectively and with good data which system would best get us there. Thank you for your time.
First, allow me to say that I am genuinely honored to be here, and it's a great privilege to be here, Roy, and I'm very happy to have been invited to talk. What's interesting is I've been invited to talk on the thing I know the least about in the context of this panel, so I hope you will bear with me. What I'm going to talk about today is evolving public service delivery models. I'm going to talk about the healthcare context, but this discussion, I'd like people to situate it and think about it in the context of a remarkable change that's going on in Canada and in other advanced industrial democracies, as are the public service delivery models that built up in the latter half of the 20th century have been collapsing, and many of the assumptions inherent to them have been collapsing in the face of evolving citizen expectations and rapid technological change. And these come into conflict with the psychology and sociology of individuals who have very particular views of what we mean when we talk about healthcare, or what we talk about when we talk about any public post-secondary education. When I first started to engage with this issue in the late 1990s, I was living in Kingston. And in Kingston, we were facing a discussion about the closure of one of our 2 hospitals. And that was the big public debate. And everyone was opposed, because to everyone, 1 hospital rather than 2 hospitals meant half as much health care. And the notion of healthcare as being intimately tied to hospitals is deeply ingrained in people's views, just as the view of post-secondary education, people have views of professors giving lectures to large classrooms. But those models are crumbling around us, and this work is situated in the context of our larger question at the Mowat Center, which is, how do we continue to realize the values inherent to our current public policy frameworks in a quite different and changed context? It is my belief that that is certainly possible, that this will be a struggle, that we are working this through. How do we realize the values of Medicare and a single-payer public system, and the values that animated the Romanow Report? And how do we continue to realize that promise and those values in what we all recognize as a very changed situation in terms of what citizens are capable of, but also what electronic devices people hold in their hands. The main 2 points I'm going to make is that reform is possible within the context of a public single-payer system. and that the concerns about fiscal sustainability are overstated, and that there are organic evolutions going on every day, and people in this room are probably participating in them every day, that are bringing the costs of healthcare down every day, and that it is possible to deliver better quality healthcare. It is possible to achieve even better the kind of healthcare that we want at less cost without fiscal calamity. And so the first point I will make is that the fiscal sustainability challenge that people have been talking about for quite a while is overstated. It doesn't mean that it's non-existent, but that there are a variety of solutions to that. And the second thing I would say, which is implicit to that, is that there is plenty of money in the system to do most of the things we want, but the different provinces are situated very differently. And one of the challenges we're going to face moving forward is that different provinces are going to have very different capacities to meet their healthcare challenges. People here would certainly be familiar with the straight line of death, which has been projected now for a while and is prominent in many public reports over the last 2 years that talked about the growth in healthcare spending and unsustainable healthcare spending. The forecasts continued to suggest that healthcare spending would be going up, and it is my view that this was largely a pretext for undertaking, for arguing that our current healthcare system, publicly funded, single payer, is not sustainable, and to bring in alternatives that I don't think are necessary. And I think that the growth in the straight line projections and forecasts is overstated. For those people who've been around this debate, we've seen these issues before. We've seen rapid growth in healthcare spending in the 80s and early 90s, and then quite rapid declines over the late 1990s, and these things go in cycles. The rapid increase in spending in most provinces over the last decade has largely been driven by increasing salaries and investments in technologies which we have yet to harvest the full benefit from. In Ontario, the context for this was the Romanow Report, which suggested we needed a 2.1% annual rate of growth in the context of growth that was 5 or 6%. But we see in recent CAHSPR reports from last week something that many of us have been pointing out for quite a while, which is that all of these projections are grossly inflated. They're based on faulty assumptions, and that without even trying that hard, now I know probably ministers of health would say they've been trying hard to bring down spending over the last couple of years, and I don't dismiss that. I see some former deputy ministers of health. I'm sure they've been working very hard, but we haven't really had a lot of big conflicts on delivery models, labor relations over the last little while, and nonetheless we have brought healthcare spending, without even trying that hard, down to just over 3% probably. What we have suggested in our reports is that we should be thinking about healthcare as a high-tech industry and treat it as such. We can focus on improving quality and access even as costs decline. We should be adopting a Moore's Law approach, which is recovering the productivity gains from the investments in technology that we've made. And we should recognize that there's disruptive innovation going on throughout the system that we have not fully acknowledged or accounted for. People here would be very familiar with the strategies to bring down healthcare spending, which I would say have been, which we are just starting to use and have only been used marginally. We have not done a good job yet of bringing down the price of services to reflect the true cost of delivering them, and people in this room would be very aware that the true cost of delivering a variety of services has been declining dramatically, in part because of productivity investments and technology investments made by the public, and it has been mostly providers who have been capturing those gains, and so we need an honest conversation about compensation. This connects to the issue of pulling a lot of procedures out of hospitals and performing them as routine procedures in specialized clinics. This includes a real use of mHealth, telemedicine, and telemetry, with most of the innovations being done in the Global South. But entrenched stakeholder interests, legislative frameworks, regulatory frameworks, our assumptions about hospitals and doctors have all prevented us from really capturing the enormous possibilities of iPhones, for example, and routinization of procedures and allowing lower-skilled healthcare workers to take photos of things and ship them off to downtown Toronto for diagnoses. All of these things we are evolving and changes are happening, but too many of these things, which would be which would produce real savings, are prevented not by the Canada Health Act, not because they violate any of the values of Medicare. In fact, they may provide much better service to have someone diagnosing it who sees 1,000 of them a day rather than someone in a small town who sees one a month. But all of these things, network care for chronic diseases, navigation systems, the systems we have are so complex in the healthcare system. I mean, in the Ontario government, we have now, and I say this with all due respect to the complexities of the healthcare system and the public service challenges, but in Ontario and other places, we are identifying navigators to help patients navigate through the system. And if I may be blunt and swear, I mean, we have created a new job to help navigate the bullshit that we ourselves have created. That's how embedded the structure is. And we are working at these things to create better access to care, better quality service, and the navigation systems are designed to get to the question of the appropriateness of care. Steve talked about pharmaceuticals, obviously family health teams, other forms of accountable care organizations. I would think that the dramatic changes over the last decade on transparency and reporting have driven improved quality where hospitals and regions care about their performance and their outcomes. And we have done a great job in many services in reducing hospital stays, adopting better models of community care, home care. All of these things, however, are taking place organically, naturally, and I would say without yet concerted systemic effort. And if we adopt all of these strategies and a variety of others, I think that it is very plausible that we can be delivering better quality outcomes, better health outcomes, better services to patients without significantly increasing costs. The other thing I would just say is that in Canada today, we have dramatically different fiscal capacities across provinces. Alberta, Saskatchewan, Newfoundland and Labrador now have abilities to provide health care at significantly higher levels than other Canadians, and that is an issue that I think as a country we're going to have to work through. Thanks very much.
I have the opposite job of my colleague Stuart Soroka. He got to go first. I get to go last, and everything's been said. But one of the things I do want to say right off the bat is to Mr. Romanow, which is thank you. Merci. Spasiba. I even remembered that. Thank you for spending all that time on the commission, having the report, and being such an advocate defender of it since then. Thank you very much, Mr. Romanow. One of the things I did, because I was a smart aleck kind of assistant professor at the time, is I wrote a review of the Romanow Report when it came out. And the title of the review was, A Spirited Defense of the Public System, but Is There a Map for the Road Ahead? So I'd like to put a coda to that title and say I think there was a map in the Romanow Report. It's just I think we've had a few navigation problems in our political system since then. But there was indeed a map for change and for progress. I've been asked today to focus on federalism, and I'd like to do so by talking about the high politics of federalism, the good, the bad, and the ugly. But to reiterate, perhaps this time at least, c'est pas la faute du Québec. This is not Quebec's fault of what I will be talking about. All right, we know, what was the trick? Oh, there it is. We know some of the main points about federalism in healthcare is that federalism is both something that can give us laboratories of democracy, as we've seen in Canadian healthcare experience, but also lends itself to the kind of toxic politics that Mr. Romanow actually talked about in his report, and that we often see healthcare as a lightning rod for larger kinds of problems or jurisdictional conflicts and money conflicts, and certainly that's been the case in terms of federalism over time. And federalism, of course, is not just a thing, it's a process, and healthcare has been an important part of that process in Canadian history. Federalism and healthcare have been intertwined in terms of the changing fiscal relationship that the provinces have had with the federal government, and certainly here healthcare plays a prominent role. Here are some of the major points along that way: the National Health Grants, the Health Insurance, Hospital Insurance and Diagnostic Services Act, and medical care insurance. And federalism is also something that often comes at the price of a conflict about changing the rules of the game. So that federalism is part of a political game that gets changed, that changes over time, and the question is always who's making the rules, who's making the choices about what changes. And prior to the Romanow Report, we know that fiscal federalism had been going through some pretty difficult years. Greg Marshallton made reference to that earlier this morning. One of these was the way in which the funding transfers or the funding decisions were changed, some would say unilaterally. Another change was the Canada Health Act, which for the first time would actually put levers on provinces in terms of the transfers to the provinces in the matter of healthcare. Again, even though Quebec did have some major problems with the Canada Health Act, ce n'était pas la faute du Québec in terms of what Quebec's own legislation looked like at that time. And I'm getting the hang of it, but not quite. And of course, the infamous or famous Canada Health and Social Transfer, which was also referred to. So all of these kind of different points in the federalism line serve as a backdrop to what was going on in terms of larger political questions about the fiscal relationship between Ottawa and the provinces prior to the Romanow Report. One of the things that came about almost immediately after the 1995 CHST was, of course, the idea about what to do about healthcare funding, and more particularly what to do in rewiring the relationship between the provinces and the federal government. So the National Forum on Health, which predated the Commission, the Health Transition Fund, and as early as 2000, some major new funding in terms of a health renewal agreement. And then, of course, the identification of the Romanow gap. You'll be happy to know, Mr. Romanow, that this is now a question on every exam I give in my health policy class. Every student who's gone through McGill University knows what the Romanow gap is. And the reference to it as being a gap that has to do with fiscal concerns and the need for multi-year stable funding, as if someone couldn't have thought of that earlier, sorry, but this was a very important kind of an element of innovation in terms of the relationship between the provinces and the federal government on healthcare, the commitment to a public system, and to public funding in that system, and using fiscal federalism not just as a funding mechanism, but as a leverage tool for specific kinds of change, which was also very important in the Romanow Report and has been referred to earlier as well today. Of course, what we got were almost immediately two ways in which this panned out following the Commission's publication, the 2003 Accord on Healthcare Renewal and the 2004 10-year plan. Many of you in this room were involved in at least one or the other of those, so I don't have to go through all the bases, but the idea is that this was major, new, sustained funding, public funding for the Canadian healthcare system across the provinces. But there was another Romanow gap. And I think that we want to recognize that in this report, Mr. Romanow and his colleagues were identifying something else. They were identifying the need to do something about federalism and healthcare. There was an enormous amount of research that came out of the report that dealt with the issues surrounding federalism and healthcare. There were recommendations about how to provide forums for information and exchange that Greg referred to this morning. The idea of bringing policymakers to task for the toxic politics, and Mr. Romanow's favorite line about ending the long-distance hollering, right, between political leaders on these kinds of issues that weren't just political issues, but were actually really important things for Canadians, for every Canadian across the country, and reaffirming that there is a role for federal leadership in healthcare. Ramping up research was, anyway, personally very important to me because I was one of the people who was chosen to do this research. My colleague Marie-Claude Prémont is here. There were, in fact, many trees cut down in Canada to publish all of this research. But on the other hand, it really gave us for the first time a corpus of research on questions surrounding constitutional issues and federalism in terms of healthcare reform. So that was a great contribution that the Romanow Report gave us as well. Providing forum for information and exchange. Of course, the Health Council of Canada is co-sponsoring this conference, so I had to make a plug there to John and to his colleagues, but also the fact that this was a recognition that there needed to be more talking to one another, and that something along the lines of the Health Council of Canada could do so. And of course, the Council of the Federation, which of course came after the Romanow Commission, but in effect also had as part of its mandate, and here, c'était la faute du Québec, here there was leadership from Quebec, part of its mandate, a way in which provincial premiers could come together and be able to speak, not necessarily as one, but to understand each other on questions of real importance to Canadians, such as healthcare. However, the politics of healthcare are still out there. And one of the things that the Romanow Commission did not do, because it couldn't do, was to end that kind of political scenario or political tensions around healthcare. When you're talking about that much money and that much power, it's very difficult to do so. What has changed, though? That was then. I like this photo because it's all these men in suits, none of whom are in power anymore. Interesting, huh? What a difference 10 years makes. There you go. This is from the 2003 Health Accord. There they are, all lined up. Notice who's in the middle, the Prime Minister. And notice who's talking, also the Prime Minister. There's Jean Chrétien. That was then. Whoops. This is now. And I want you to, this won't be a quiz, this won't be on your quiz at the end of the day, but I want you to take a look at the differences in terms of these photos. We still see to the left all these men in suits. They're finance ministers, right? And the people at the head of the table are the Minister of Finance, Jim Flaherty, and the Governor of the Bank of Canada, Mark Carney. So decisions about health care are now, and this is just at about the time when the finance minister kind of unilaterally spoke about what was going to happen post-2014 in terms of the healthcare accords. This is how the decision was made. And on the other side, to the right, you see at least some ladies in the room, finally. Flowers, all kinds of things that suggest a little less tense atmosphere. But what you don't see are many people from federal. So you don't see, this is from the Council of the Federation, right? So the idea is that, well, what's happening? Why aren't people talking to one another? Why isn't there that exchange of high politics? It's because we don't have federal provincial kinds of conferences in the way that we used to in the past. All right, so we do have a changed political landscape. Parties and elections have happened since 2002, right? We have new parties. We've had a series of elections that have changed partisan composition, not just federally, right? Also in every province across the country. But the saliency of health, the saliency of health care in every single one of those elections is still there, right? It's still a salient political issue, even though these partisan compositions have changed. We have a fiscal content that's changed. Matthew spoke to this, and I think it's a very important point. There's been a revolution in who's a have and who's a have-not in Canada. I know that's politically incorrect to use those terms, but I press on. And of course, we've had the impact of the economic recession and its aftermath. And finally, we've had a very changed political landscape because of new ideas, interests, and institutions. So my colleague Stuart Soroka talked about public debates and opinion shifts. We know about the changes in terms of interest mobilization and whose voice gets heard in our political system. And of course, new actors in the healthcare debate, in particular the courts, and reference was made to the Shauli decision this morning as well. So we are living in a different political time. Things do change over 10 years in this way, and they have an impact on federalism and healthcare. Finally, because I guess, whoops. We have to think about whether or not we're still playing, or there's still something called a federalism card that's being played in our political system, about whether or not this kind of a card can be used in the same way post 2012 than it has been in the past, about how do you raise the ante for federal transfers, and how do you legitimize need in the healthcare system, how do you use federalism as a leverage tool in that regard, and the way in which we're going to have, I think, in the next few years, a renewed debate about the coherence of the healthcare system and whose facts are right in terms of evaluating what is wrong and what needs to be done with healthcare in Canada. These are the outstanding challenges in federalism in healthcare as far as I see them. The Romanow gap, in terms of the fiscal gap that was identified in the Romanow Commission, we're likely to see a federal government maintain a spending role, but highly unlikely that this is going to be used as in the terms of leverage in the way it has been in the past, the new gaps in provincial fiscal capacities, and which will open up new linkages between health or exacerbate the linkage between certain types of access to healthcare and inequality. And of course, the other Romanow gap that I've just identified, leadership in healthcare reform, policy learning between provinces, and some of the unaddressed issues that were referred to earlier by Steve and others. I'm going to leave you with this, with this image. Of course, the US election is all anyone talked about this week. Sorry, Mr. Romanow, we should have been talking about the 10th anniversary of the Romanow Report. But let me make a link to that important political event by saying that what we can learn from the experience of the first mandate of Barack Obama is that it was defined by a struggle to reform the healthcare system in the United States. And what we saw there was an increasing polarization in which healthcare became a proxy for some pretty deep divisions in American political life. And I think we may be seeing that replay out itself in the Canadian context. We saw how institutional contours, such as the Congress, such as federalism, provided both roadblocks and opportunities in that debate. We saw how the turn to regulatory levers became really important in terms of thinking about what was possible in healthcare reform. And finally, that the path dependency that so many people said was inherent in the way that the United States did business in healthcare reform was there, but change is not impossible. And I think Mary Claude was telling us a little bit about why that is important in terms of thinking about that in healthcare reform in Canada. Thank you very much. Merci beaucoup.
Thank you, Antonia, and all of our speakers. So we've really covered a lot of territory in this session. I mean, the idea was to start with sort of what programmatically were the pressures, and what are they now, and what are some of the options for the future, and then looking at fiscally what were the pressures and what are some of the options for the future, and then looking at federalism. And so we have covered a lot of territory. I want to call on a couple of people. I know Nadine Henningson's in the room. I don't know where she is, but Steve's mandate was sort of to cover all the main pressures, and back in the day, pharmacare was certainly one of them. Home care was another big one, and people have alluded to the waitlist challenge. But Nadine is kind of, I don't know, the queen of home care in this country. So Nadine, tell us your views.
Well, thanks for that introduction, Lillian. I'll just let you know I wore my bright plaid pants so she could find me. But I'm the Executive Director of the Canadian Home Care Association. I'm also the President of the Canadian Caregiver Coalition. And I know that a number of our panelists this morning talked about that home care isn't part of Medicare, and that probably is inhibiting the growth and the rollout of home care. Well, I think that I'm going to pick up on Matthew's comment about your organic evolution, because what we've seen since the Romanow Report is that it was a real catalyst. It was a catalyst to home care for a number of reasons. First off, it really brought to the attention of policy planners and funding mechanisms and main decision leaders is the role and value of home care. And then what also happened at the front line is, with the emphasis from the Romanow Report and then the subsequent plans, is that there was a real focus on quality and accountability at the front line. And this whole really moved towards doing a lot of partnerships of home care with acute care, partnerships of home care with primary health care, integrated partnerships for quality end-of-life care. So there really was a lot of organic evolution in home care. Now, we still have have a lot of challenges that we face, and I think one of them, I guess it's a good and bad, or a yin and yang, is that one of the things that we've found happening across the country is there's a real philosophy change or culture change at looking at that we have to move away from the episodic acute care to the long-term chronic care. And we've actually seen that in provinces, in BC. Their whole philosophy for health and wellness is home is best. That's their motto, and that's how they're building their health system. In Ontario, we see home first, and in Nova Scotia, we see home again. So we're seeing that movement. But I think our biggest challenge, and that I'd like to throw out to this whole group, is how do we pick up on that philosophy change and that culture change? How do we, as healthcare consumers, as family members, as key leaders in the home care sector or in the healthcare sector, how do we pick up on that philosophy change and really show that we have to move towards home and community and away from that episodic acute care?
Great. So now I'm going to call on Jerry Hurley, who I think is over here. And the reason I'm calling on Jerry is that somebody alluded to the CIHI, Canadian Institute for Health Information, work that's been done around cost drivers. And I know Jerry was one of the co-authors of that. And I'd like just some reflections on what Matthew had to say about the sustainability of the system and some of the opportunities and challenges for that matter.
Sure. I mean, I think I would... Is this on? People here?
You have to say who you are and where you're from.
Jerry Hurley from McMaster University, Center for Health Economics and Policy Analysis. Obviously, we do face fiscal challenges. I would tend to share the view of Matthew that, in fact, they are manageable if we make the right kinds of decisions as both the economy unfolds and the healthcare sector unfolds. There's big challenges, but the cost driver, once you get rid of, the aging and inflation and so forth, the biggest part is this, what often called the residual, or the unknown. Stuff we basically say, we don't know what's causing this. But in fact, we do know a lot about it. It's policy. It's deliberate choices that governments and various policy organizations make around the healthcare system. And we need to get inside that, what is now a kind of a black box, to understand better what kinds of policies will help us handle the cost challenges. Now, we did that in the mid-90s. Of course, we were successful. I think the perception now is, of course, we did that in a fairly crude way through stringent global budgets. This time, we're going to have to work a lot harder at how do we do that and improve quality at the same time and help to realign the system. Because I think it's a perception that we did cut costs then, but we didn't get the system change that we might have been hoping to come out of that. So I think that's the real challenge that we face now is how do we both control costs and get the system change? And in that respect, I'm an economist, so I'm not supposed to know this, I guess, but I mean, that's my question actually to Matthew and others. The list you put out, we've known for a long time about lots of things we should be doing in the system. My sense is our challenge has been, how do we actually, on the ground, make the change happen, get the organizational change that can therefore integrate these new technologies and so on and so forth. And so in my mind, I see that as a bigger challenge in some sense than the purely fiscal side of things, because only that's what's going to change the system. So I'll stop there.
Did you want to comment there, Matthew?
I'll say a brief comment about both observations, actually. So I'm glad that you generally share the diagnostic or the analysis, and the question is then how do you move forward? And I think the question or comment that you made is that organic evolution is taking place, and practitioners are undertaking it all of the time. The question is when legislation and policy kind of catches up and how you get that to happen. And I don't have a short answer or a magical answer, but what I just look at this more broadly historically, and that is that our evolving practice is not our legislation and regulatory and policy frameworks are not keeping up with evolving practice, and how physicians and healthcare providers want to practice and what they're incented to do and how they're paid isn't necessarily consistent with what they actually think would be the best thing to do on a day-to-day basis, whether that's, sending emails or taking photos of things and sending them to colleagues, and all of these things that are part of the healthcare system that may or may not be remunerated. I mean, we all recognize that, to pick up on your point, getting people, if we want to bend the cost curve, getting people out of hospitals and away from doctors' offices should be the main strategic objective. And there are all kinds of other ways to provide those services. So I think that the question is about, I think, also established legislative and regulatory frameworks that need to change. So the focus on doctors and hospitals in Medicare, that has to change. And so it's just part of a long process. And that includes entrenched stakeholder interest. And that's not being critical of anyone. That's just pointing out that people have ways of doing things and institutions build up around that. And so that's challenging that. And that's identifying a preferred end goal, which is all consistent with the Romanow Report and our values, and thinking about how we get there more efficiently. And how we design and deliver right now isn't how we would get there if we were designing this thing again.
So I'm going to come to Reza in just 2 minutes. I just want to call on, I think Terry Sullivan's in the room. Am I right? I think I see him way at the back over there. Terry, I wanted to ask you on this question of sort of federalism, not because you're an expert in that, but because I know I'm hearkening back probably 20 years now to the Premier's Council on Health that I think you were the staff person of, and just some of the challenges of working within government to try to effect change. And that was within a single government here in Ontario, bringing different ministries together for a whole of government approach, let alone something that brings a whole lot of different governments together to care about health. But I'd like you to maybe make a comment here, and then we'll go to Reza Dieber in the middle here.
Well, that's going back a long ways. I'm going to sound like an old man. I do think that was an interesting approach, bringing together elites and cabinet ministers around the cabinet table. It offered the promise of actually cutting off the very strong interests which had captured and do capture and continue to capture, as they are right now in the midst of heavy bargaining with organized medicine in Ontario, the attention and interests of governments in order to say, if we want to drive improvements in health, what do we need to do outside of the health sector? How do we make disproportionate investments? So I think it was a very interesting experiment, and I'd say one that hasn't been well replicated, and offering a two-bit opinion on this, one in which many of these checklist models and a whole of government approach don't actually get to the politics of the economic capture of large interests at the cabinet table in cabinet government. So I think from the point of view of a provincial jurisdiction, you need something more than checklists affecting the cabinet. You need people who can counter the voice of strong interest to make investments outside of the health sector. But if I can offer one little comment while I've got the floor here for a moment, I think one of our major challenges in looking backwards over the last decade has been one of the jobs which we all had great aspiration for was to actually focus on improved performance in our healthcare system. And I'm afraid we have not got that. We have doubled in real terms the amount of money we spend on the healthcare system. I don't think that's a good thing or a bad thing, it's just a fact. But our performance characteristics have not followed that. And we have had very weak reporting. The Health Council of Canada has tried to do an admirable job in the face of continuous resistance and sabotage by member governments in actually telling the truth about how well they're doing. And I think CAHSPR is also trying very well to kind of put some facts on the table. But the fact is, we don't do a good job of telling the public how well we're doing and how poorly we're doing. And that is one of our missing links in the whole agenda, which was launched by Mr. Romanow. Thank you.
Thanks, Terry. Reza Dieber. And can you introduce yourself, Reza, please?
My name is Reza Dieber. I teach at the University of Toronto. And I wanted to echo one of the points made by Matthew, and just a caveat, because one of the interesting things that happen when you change your strategies of how you deliver care, you also may move how particular costs are classified. I've done, Greg is putting out a very neat book on bending the cost curve, and one of the things I found looking at the data is that when you move care out of hospitals, you move the same costs onto different lines. So when you move care out, drugs may move from the hospital budget to the drug budget. But what's even more striking is that the clinic care moves on to the physician budget. And I have been wondering how much of this panic about the increase in costs for physicians is merely a reclassification of care that had been in hospitals, which has moved into independent health facilities and therefore has moved lines. And some of these, quote, high-billing physicians may simply be these changing care packages. So again, if we're going to be careful about what we're doing on prospects, I think it's important to know what we're measuring and make sure that we're not defining the question wrong. Same thing with home care. All of the non-professional home care services are not captured by the data. So whether or not we are doing these non-professional home care services, we don't know, because that's not being picked up and not being measured. So one of the pleas is for more nuance in looking at what the indicators are, as opposed to simply assuming the sky is falling. But my question is for Antonio in future, because at a previous CAHSPR conference, the idea was floated of taking the health transfer and moving it entirely to tax points, which of course means the Canada Health Act would not be enforceable and no one could undo it. How real do you think that prospect is that the government may choose to move to tax points? And what, if anything, happens to the healthcare system if that happens?
So, I mean, I don't think it's apocalyptic, any future scenarios. But certainly the idea of kind of reverting to a model of federalism that sees, arguably, that provinces are at the center of organization, reform, and delivery of healthcare is one that obviously is something that has taken hold in Ottawa. The tension and the challenge is the extent to which there can still be leadership in some form for the federal government. Because one of the problems that was identified this morning is there's always a problem of policy drift, right? And it doesn't mean that even if every province is busy at work reforming its healthcare system, it doesn't mean that that on its own is not a good thing. But if that can't be coordinated or somehow have some process for learning from provinces, some kind of forum and formal exchange, I think that limits if we really can talk about a Canadian healthcare system. I don't use the word Medicare. I don't think it's the proper term to explain what we have in Canada. But on the other hand, I think we all know that every person in every province is still a Canadian. And so in that respect, there is some kind of a leadership role to be played that has to go beyond simply signing checks on the part of the federal government, or not signing checks, as the case may be.
Briefly comment on that question, because I guess in my file, as it relates to prescription drugs, it's probably the biggest tension. The two lovely slides that I didn't talk about, the lovely photos, one of a sunset showing $100 billion and the other of a contract being signed that showed $75 billion, were to highlight the point that in that sector of the marketplace, or at least that sector of healthcare, the business practices globally are becoming one where organized purchasers of medicine, usually public bodies, but also social insurance institutions in Europe, are negotiating contracts for pharmaceutical supply, just like our hospitals have been doing for decades. There's a couple $100 billion up for savings globally in this file, which is a good thing, and Canada's share of that is probably on the order of $4 billion. The challenge in terms of federalism is that it puts each of the individual provinces in a position where they would be negotiating, in a sense, on their own. And the stat I often use in reference to this is that the Ontario public drug budget is over $4 billion. The GDP for Prince Edward Island, every dollar of income on that island is $5 billion. how can they possibly negotiate contracts with pharmaceutical companies who are, by nature of the industry, global enterprises? How can those two provinces negotiate on equal terms? And it's nothing to blame Ontario, because the people running the drug plan in Ontario now are, I think, doing their good Canadian duty of helping other jurisdictions. But it's a file where we truly, dearly need cooperation, probably integration of processes across provinces. And horizontal cooperation is far more difficult than vertical. And I think that speaks to the fact that, at least in this file, we need a federal government.
Can I just say one thing, which is that I don't think a tax point transfer is in any way, I like to make predictions publicly with this many people in a room, that is not going to happen in any way, shape, or form anytime in my lifetime or in the foreseeable future, because it's become clear that a tax point transfer discussion faces a huge decision for a federal government, which is the tax point transfer equalized or not equalized? And provinces have exceptionally different views there. In the past, they've been equalized, which isn't really a tax point transfer, right? Because you're giving people, the poorest province, tax point transfer, but then you're giving them a bunch of extra money. So it's not really like they have their own control of their revenues that they are raising from their own tax base. And I don't see other provinces agreeing to that in the future. So I don't think you can get over that big hurdle at the moment.